Hello colleagues, this is vascular thromboembolism prophylaxis in hospitalized medical patients topic. And this is me, Dr. Yusuf Hamid, the MRCP tutor medical courses instructor from passonexam.com. Will depend on up-to-date as the source for this talk. Let us start. Why this topic is important? There are two reasons. Risk of venous thromboembolism is more than 50% of hospitalized medical patients. Number two, pulmonary embolism is the most common preventable cause of hospital death. So the questions here, how to approach those kind of patients? We have 3 steps to be followed. Step 1, thromboembolism risk assessment. 2, bleeding risk assessment. 3, selection of prophylaxis method. Start with risk assessment. Categorize patients to 3, high risk, moderate risk, and low risk. Start with high risk patients, including 3, critically ill patients, ICU cases, 2, cancer patients, and 3, ischemic stroke. Moderate risk include patients who have at least 1 out of 11 risk factors for venous thromboembolism. I will mention it. 1. Old age more than 60 years. 2. Heart failure. 3. Acute respiratory failure. 4. Renal failure. 5. Inflammatory bowel disease. 6. Sepsis. 7. Previous venous thromboembolism. 8. Prolonged immobility more than 3 days. 9. Obesity. 10. Inherited or acquired hypercoagulable states. 11. Pregnancy. Low risk patients, no risk factors for venous thromboembolism. Step 2, bleeding risk assessment. Risk assessment, we look for 3 things: intracerebral hemorrhage, active GI bleed, and platelet count less than 50. Step 3, selection of prophylaxis method. For patients have moderate and high risk plus low risk for bleeding, for those patients we use low molecular weight heparin or unfractionated if creatinine clearance less than 30. For low risk patients, we use early ambulation with or without mechanical methods. For high or moderate risk patients plus high risk of bleeding, we advise mechanical methods of thromboprophylaxis. Here, important note, combined method, low molecular weight heparin and mechanical are recommended for all patients with ischemic stroke starting at admission except in 3 occasions. Number 1, low molecular weight should be delayed 24 hours after thrombolysis of stroke. 2, no need for low molecular weight heparin in patients with TIA or minor stroke who are treated with dual antiplatelet therapy. 3, no need for low molecular weight heparin in patients receiving anticoagulation for another indication. Next question, which doses are recommended? For low molecular weight heparin, we have two adjustment for renal impairment. If creatinine clearance more than 30 will give 40 OD, or less than 30 will give 30 OD. For obese patients, if more than 40 will give 40 twice, if less than 40 will give 40 OD as normal. For unfractionated heparin, we have two dose adjustment. For obese patients, more than 30 will give 5,000 to 7,500 3 times daily, or if no obesity will give 5,000 twice daily. For fondaparinux in patients who have HIT, it is contraindicated if creatinine clearance less than 30, or if 30 to 50 will give 1.5 milligram, or if more than 50 will give 2.5 milligrams subcutaneously. Thank you. This is the end of this talk. Let us see you next video.